قدامي لايف اون يوتيوب.
طب الحمد لله.
بص يا باشمهندس، حضرتك تبعت اللينك بقى للدكتور ناصر عشان يبعته بره.
تمام.
ماشي يا
هبعته لحضرتك على
باشمهندس.
الواتس.
تمام. دكتور بولس،
نعم.
حضرتك دلوقتي ابدا الشغل.
دكتور ايهاب دلوقتي بقى الهوست يا باشمهندس.
باشمهندس
يا
عادل،
دكتور.
خلي دكتور ايهاب سامي الهوست.
تمام
خلاص دكتور ايهاب سامي دلوقتي
خلاص
الهوست.
اوكي
حضرتك
حاضر.
ابدا بقى دلوقتي. خلاص اوكي
ماشي.
النهارده قدرنا ان احنا نجيب دواء كويس من بريفير اللي هو كان اصلا دواء ياباني قديم اعتمدته روسيا مؤخرا في الايام القليله الماضيه كعقار في الوقوع بتاع كوفيد. هذا العقار خبر طيب جدا لينا كلنا، موجود النهارده في مصر، تم تصنيعه وموجود للمواطن المصري. هو بيكون للحالات البسيطه الى المتوسطه بعد 7 ايام او 10 ايام او 14 يوم. 14 يوم في وقت من العلاج نسب الشفاء تزيد عن 90%. مراحل الانتاج احنا كده قدام اول مرحله هي مرحله التحضير. مرحله التحضير هي المرحله اللي بيتم فيها اذابه المواد الفعاله والمواد الغير فعاله بتنفي التحضير اللي ظهر قدامنا. بعد ما بيتم اكتمال التأنيب بنسحب عينه بنبعتها لقسم كواليتي كنترول. القسم ده بيتم تحليل العينه. بعد الفلتريشن بيبقى المنتج بتاعنا استرايل او معقم جاهز للمرحله اللي بعدها اللي هي مرحله الكميه. طبعا مختلفه حسب المواد الخام اللي بتيجي من بره، لكن احنا عندنا سعه التانك 200 لتر، ممكن نحضر باتش يطلع 10000 واير في اليوم.
احنا هنا في لاب ده مخصص بس لتصنيع المواد الخام الفعاله. اللاب ده بيتم فيه التفاعلات البرمجيه اللي من خلالها بنقدر ان احنا نعمل الماده الخام فعاله. الريبروسيفير كماده خام فعاله طبعا.
يا ولا سلايد نونو طيب
الاجزاء الصغيره ديت مع بعض عشان خاطر تدينا الماده الخام الفعاله الاخيره. خلال الفتره اللي جايه احنا هنقدر نقول ان احنا هنعمل ممكن على يعني نوصل لحد
احنا عندنا فرق بحثيه متخصصه بتبدا تشتغل على المواد الخام في وقت متزامن مع الابحاث اللي بتبدا تشتغل بره، بحيث ان احنا نقدر نوفر الدواء للمريض في الوقت المناسب ليه مع نزوله في الاسواق.
حتى المقابل ده ما
Please mute the mics, please mute the mics.
او المعالجه اللي بنعالج بيها القدرات اللي هي بتحتوي على المواد الفعاله والمواد الغير فعاله من خلال رش حلول معين على البودره. بعد مرحله التحضير ما بتخلص بندخل على المرحله الثانيه اللي هي الميكسنج او التقليب. المرحله دي مهمه جدا لان هي بتضمن توزيع الماده الفعاله في خليط البودرات بنسبه 100%. ثالث مرحله بتدخل مرحله الكومبريشن او كبس الاقراص، والمرحله دي تعتبر كريتيكال شويه وبنقيس فيها بارامترز كتيره عشان نضمن ان القرص لما المريض هياخده هيبدا يفرز الماده الفعاله في الوقت المطلوب زي الدواء الاصلي اللي بينتج في روسيا واللي بينتج في اليابان.
Good evening, Dr. Nasser.
Shall we start now? I think it's
Yeah.
time to start.
Yes, doctor. Yes, doctor.
Yes, yes, Dr. Nasser, please start.
Good afternoon, everybody. It gives me great pleasure to welcome all of you in webinar number 5 among the series of webinars organized by the Egyptian Society of Neurological Surgeons, ESNS. On behalf of all Egyptian neurosurgeons, I would like to express my sincere appreciation for the presence of our great speakers. Let me introduce my friend, Professor Basant Misra. He is well-known neurosurgeon. Actually, he doesn't need any introduction. He's the current first vice president of the World Federation of Neurosurgical Societies. Let me introduce our eminent Egyptian neurosurgeon, Professor Osama Al-Ghandour. He is the former dean of Faculty of Medicine at Azhar University and honorary president of the ESNS. Let me introduce the moderator of this session, my colleague, Professor Dr. Amr El-Samman, Professor of Neurosurgery in Cairo University. Thanks to all of you for accepting our invitation and for contributing to this activity. Let me give the speech to Professor Amr El-Samman in order to start this session.
Well, thank you, Professor Nasser. Good afternoon, everybody. I'm sorry for the delay. Usually this is for technical issues. And without any further delay, we'll start with Professor Misra. Are you present, sir?
Yes. Yeah.
Okay, sir. So the first speech will be about microsurgery of giant aneurysm. And you can start sharing screen, sir. Thank you.
Are you seeing my screen?
Yes, sir.
Yeah. Okay, good afternoon. Thank you, my friend, Professor Nasser, Professor Osama, Professor Amr, and thank you very much, Egyptian Society of Neurological Surgery. It's a privilege to be contributing to this seminar. I'm seeing a lot of my old friends there. So without delay, I'm going to discuss today our experience with microsurgery of giant aneurysms. So as we know, giant aneurysms are aneurysms which are defined as anything which is 25 millimeter or more. There are many problems in the management of giant aneurysm. They have wide neck, they have involved branches, perforators, thrombus, atheroma, calcification, complex anatomy, and so it is difficult to treat them. So why treat? Because if you don't treat, the natural history is disastrous. Left alone, most of them either have a compromised life because of the neurologic deficit, or they die within 2 years. So they need treatment. And unlike the common belief that they're thick-walled, calcified aneurysm, they don't bleed, they in fact have a higher rate of hemorrhage than the normal saccular aneurysm. The risk of hemorrhage in the giant aneurysms is much higher, which is about 10% per year. Now, with the advances of endovascular treatment, why not treat all these as endovascular treatment? Unfortunately, in spite of many advances, there are many problems with endovascular treatment. As you can see, some of the published literature in 2016, 16 patients with flow diverter, the major treatment, at 2 years, none of them had complete occlusion. And many of them, another study in 2016 by Brasiliensis, in MRI, many of them had evidence of ischemia and infarction. And these are further treatment. You see the meta-analysis, the mortality in the endovascular treatment group is about 15% in all aneurysms, and in the giant aneurysms, it is higher. And many of them, about 40% of the patients had deteriorate after endovascular treatment. So these are not treatments which are always can be done for giant aneurysms. So like any other aneurysm, the basic has to be the respected wide Sylvian fissure opening so that you reduce retraction. You do not compromise any veins. All the veins have to be respected so that you leave veins in between with the arachnoid trabeculae and don't damage it. And many of these patients, we can treat it by modern methods of vascularization, revascularization, and bypass. So for the young neurosurgeon, if you need to be interested in cerebrovascular surgery, one need to go to the lab and learn the revascularization technique, the bypass techniques, because that's going to stay. It doesn't matter how advances endovascular treatment. Many of these complex patients have to be treated by endovascular treatment. Another thing which we have found in our practice, which is useful, is the skull-based approaches. Paradoxically, while skull-based tumors are more and more we are treating by conventional approaches, more and more complex skull-based approaches are used for these giant and complex aneurysms. Because while tumors give you space and you can use that for taking it out, every single millimeter of extra space in giant aneurysms is useful to reach the parent artery for temporary clipping, temporary occlusion before you clip the giant aneurysm. So using much more skull-based approaches in vascular neurosurgery today than in brain tumors. So you see, this is OZ approach has been quite a useful approach for us. Sorry about that. Okay, I'll give you some examples. And the another basic is the temporary clipping. And this is a giant aneurysm of ICA, inferior wall, you can see it. And we have also found the usefulness of adenosine for temporary cardiac arrest. In spite of temporary clip, you can see big proximal and distal. When the aneurysm is giant or large and is thrombus, it is stuck to the skull base. And we have put temporary clip and we are trying to define so that we release the fundus from the skull base to put the clips. And when we do that, quite often they rupture and they bleed massively in spite of the temporary clip, as you can see it here. And this is the time when you have a temporary cardiac arrest with the help of adenosine, which gives you some seconds of time to use patties to take care of the bleeding point so that you have a clean field and you have used adenosine. Now you can see that so that we can start putting permanent clips. So before putting the permanent clip, we had to take out the distal clip because that was taking space for our clip. And then we put multiple fenestrated clips, both proximal to distal and distal to proximal, and the blade parallel to the parent artery so that we preserve the parent artery and take care of. That's after the clipping, the ICG showing the parent artery intact. So a few seconds of this adenosine does help. And this is, you can see the post-op. So many exclusion options we can use. You saw that fenestrated clips like this. And then you can do aneurysmography when you do have a posterior circulation. I'll show you one video there for these basilar top aneurysms. And then exclusion options, many exclusion options as you can see here. You can do resection anastomosis and in situ bypass and so on. So I'll give you some examples how you were treated. This is an ICA aneurysm, proximal unruptured in the cavernous sinus, presented with ophthalmoplasia and painful. So we did a patient with the balloon occlusion test. Patient tolerates the balloon occlusion test. He's 70 years. And it's a very simple treatment of occlusion of the carotid in the neck is all that necessary when they tolerate the balloon occlusion test, especially in elderly person. When they do not occlude or a patient has something like this, this is a gentleman in his late 50s, early 60s. All his vessels are diseased. You see the right ICA disease, the left ICA is disease, the posterior circulation disease, all are dolichocephalic. Patient presented with progressive ophthalmoparesis and visual compromise. We didn't actually know how to treat it. So we observed here for a year, but patient continued to deteriorate in his eyesight, mainly on the right side. So we had no choice but to do a bypass. That's what we did, high flow radial artery bypass graft from ECA to M2 and occluded the artery, carotid artery in the neck. So we bought in a time. His ophthalmoplasia improved, his visual compromise stabilized, but he's going to have problem because all his vessels are diseased. But we have bought him some time. Now this is another very interesting patient in a young man who had a disease artery, the whole ICA is diseased, and this burst in another hospital. Patient went into coma because of acute subdural hematoma. He had a decompressive craniotomy, survived, and was sent to us for definitive treatment. He also had a basilar top aneurysm. But this is the aneurysm which has produced the problem, the acute subdural hematoma, from which he went into coma. So by the time he came to us, he was asymptomatic. We advised treatment. He ran away from us, not unusual for my country. So what we did, again, we did the same thing, a high flow bypass graft, but this aneurysm was 8 centimeters. So the radial artery was not sufficient. So we had to open the aneurysm, decompress, and then put the bypass graft, and then occluded the carotid in the neck and also in the ICA intracranial proximal to the ophthalmic artery. So after that, we sent the patient for endovascular treatment to our endovascular colleagues, but that failed because the PCA was coming out of the aneurysm. They couldn't do it. Sent back to us. And so we had to treat this posterior circulation, the basilar top aneurysm. You can see that. That's the third nerve. And this will be a trans-Sylvian approach. We have opened it up. Now we are drilling the posterior clinoid, intradural drilling of the posterior clinoid to give us few millimeters of extra space. That's the third nerve there. You can see this is a difficult procedure, but we need to do that to get that extra space. There's intradural drilling of the posterior clinoid. Now, once you have done that, now that's the basal artery, that's the aneurysm, that's the PCA there. You can see this right side, PCOM entering the aneurysm and the PCA coming out from there. And we're seeing the contralateral PCA and the branch there. And that's the third nerve, contralateral superior cerebral artery. So you put a proximal clip on the distal basilar artery to reduce the torsion in the aneurysm. And then we put temporary clip on the PCOM. And then we put permanent clips. The first is a fenestrated clip and the blade is away from us. The part of the aneurysm which is distal, that's the third nerve, contralateral, PCA contralateral. So first clip is that one, and then the big clip. And more clips to completely occlude it. But when we did that, when you opened the PCOM aneurysm clip, we saw that aneurysm is still pulsating. So we had to take off the PCOM because the P1 was strong. And once we have done that, we had a good occlusion, and then we checked with the ICG and we're satisfied. But then we do the post-op after both the surgeries at a different interval of 3 months, both the ICA graft and then the occlusion of the basilar. This is patient before discharge from the hospital. Now, these are patients which cannot be treated by endovascular in spite of the advances. And this is another such example. This is a patient who had a post-traumatic pseudoaneurysm, aneurysm bulging into the sphenoid sinus, presented to us with epistaxis and blindness on the right eye. We also had hemiparesis. We sent this patient because pseudoaneurysm sent for endovascular treatment. That failed because this aneurysm, when this was pseudoaneurysm, there was a fracture segment lying in the aneurysmal wall. And their endovascular colleagues said they can't put a flow diverter that will tear up the complete wall. Again, same thing we did. We did a high flow bypass, RAG, radial artery bypass graft from ECA to M2. And we ligated the internal carotid in the neck. But you also have to trap it because a pseudoaneurysm, just ligation in the neck is not sufficient. You have to take off the ICA proximal to the ophthalmic. And that cured his epistaxis because he continued to remain blind, but his hemiparesis improved, and follow-up, he remains blind, but otherwise all right. Now, why not endovascular treatment? As we know, many of these patients, proximal unruptured ophthalmic ICA aneurysms are best treated today and has become a standard of care with flow diverters. But that's not a panacea. There are problems. Now, this is such example, a patient who was treated in another center with flow diverter, very good occlusion of the aneurysm. 6 weeks down the line, patient came with the visual compromise. You can see this edema of the visual pathway. In spite of the steroids, he lost his eyesight on the left side. There was compromise of the eyesight before endovascular treatment, blind after endovascular treatment. So that's not aphasia. This is another example of a ACOM aneurysm treated by coils and flow diverters, again developed after few weeks by temporal hemianopia. So that is not aphasia. So when we have a very large or giant aneurysm, this is a 4 centimeter unruptured giant carotid ophthalmic aneurysm. This is best taken with visual compromise. It has not bled, but visual compromise as a mass effect, completely circulating, no thrombus. This is best treated to my mind by microsurgery. This is what we did it. But this will take a long time for this aneurysmography. So we do a temporary bypass by STMC to tide over the crisis of the temporary clipping so that we don't damage the patient, as was done in this particular patient, and her vision improved after surgery. When the vessels are coming out of the aneurysm, maybe dissecting, or the trunks and branches are inside, the right MCA presented with ruptured aneurysm. Now this is the conventional treatment, but this still holds true. You can modify multiple clip technique and aneurysmography and spare the parent vessel and occlude the aneurysm, which was done in this particular patient. Another patient, bilateral MCA aneurysm, bled from the right side, presented with coma to us, and we again same thing, multiple clips, repaired the aneurysm, and then the patient was followed up. When she improved, her unconsciousness improved, we treated on the other side. So she remained hemiparatid, compromised, but otherwise all right. She has the left hemiparesis, but otherwise functional. Now again, another aneurysm which is very difficult to treat by endovascular treatment. This is involved branches, anterochoroidal, and the PCOM coming out from the left. ICA aneurysm, endovascular treatment failed because the anterochoroidal. And this is a novel technique of clipping. Again, the same opening, wide opening of the sylvian fissure. So we reduce the retraction. Now we drill intradural drilling of the anteroclinoid. And when we reach the part of the end of the part, we use diamond drilling, and we proximal carotid artery proximal to aneurysm we define for temporary clipping. And then we have distal proximal clipping, and then multiple fenestrated clip. But the novel technique here is the fenestrated clips, the blades are perpendicular. They're not parallel to the parent artery. And this is done so that between the clips, the normal arteries can be spared, the anterochoroidal and PCOM can be spared. I will, because of time, I will go fast forward and show you how it looks like at the end. So multiple clip. And then there was, when we tried to take off the fundus, there was some rupture. So we used adenosine and multiple further clips to take off the complete clip. And then we see ICG, and then also we see the ICG, and we see the anterochoroidal arteries intact. Then we do sodium fluorescein. That is better seen for small perforators. You can see better, and that's the anterochoroidal. You can see it there. You can see all the perforators, that is patent. And then we put a little bit of cotton, sliver of cotton, and put some glue. And this is how it looks, all perpendicular, straight clips, and the anterochoroidal in between, and the normal vessels there. So this is a novel technique we sometimes use. And this is another patient which on the right side, this had a patient had unruptured. The other one, which I showed before, was a ruptured aneurysm. This was unruptured aneurysm with ophthalmoparesis and headaches and visual compromise. And when we treated, we like same clips, there was some residual aneurysm, but this was an unruptured aneurysm. So we thought we'll follow it up. What happens after 3 months? That area is completely taken off. Again, the same clipping technique, vertical stacking, we call it, and you can take care of this. Now, this is a very unusual patient of a child, 3-year-old, with a very heavily calcified thrombus, giant basilar top aneurysm with hydrocephalus. The child came to us with altered sensorium. We did a shunt for the hydrocephalus. The hydrocephalus improved, child became normal within a couple of days. So we asked, this is about 9 years back, we asked our endovascular colleagues and they put 17 coils, aneurysm is well taken care of. But what happened, the child very rapidly deteriorated and went into coma, started decerebrating, the shunt was functioning. So we had to go in and do a extensive OC, extradural antroclinidectomy, and did the procedure. We decompressed the aneurysm and clipped it. Patient had a stormy postoperative course, but at 5 years, a follow-up, this is the 5-year follow-up, patient, child was going to school, normal swallowing, had some ocular motility problem, but otherwise intact, and the brainstem MRI at 5 years was completely normal. And because the child, we got away with this, again, you can see that this aneurysm which failed endovascular treatment, we could treat it. Few months after that child, we got this adult, very similar aneurysm, thrombosed, heavily thrombosed, basilar top aneurysm. Again, we did the same thing, OC approach, extradural antroclinidectomy, intradural posterior clinidectomy to give that extra millimeter of space. And you can see that this was unusually easy aneurysm because the neck was completely free of thrombus. So we could put clip without opening up the aneurysm here because the thrombus was all high up there. And so we put 2 clips, and many times this large and giant aneurysms, we need to have multiple clips to completely occlude it. ICG showing the right PCA branch, contralateral PCA, and this is the patient post-op, CT angio, post-op DSA, and many of these complex aneurysm, especially when you're putting multiple clips, giant aneurysm, always good to have a DSA because CT angio may not show everything. And this is the patient had post-operative third nerve paresis, otherwise intact, but at 3 months follow-up in my clinic, had no deficit, oculomotor motility completely improved, and he had no further deficit. So these are complex aneurysm, but again, can be treated appropriately by, cannot be treated by endovascular, can be treated by microsurgery. Now, this is a patient with a vertebral aneurysm, presented as a mass to another neurosurgeon, as referred to me as a acoustic tumor on a CT scan. But of course, this was a giant circulating 3.5 centimeter vertebral aneurysm. Now, this is where we did a far lateral approach. As I said, more skull-based approaches used. We give that extra millimeter of space, and then we open up the dura and open up the arachnoid to see the aneurysm. Now you can see that that is the aneurysm there, and we are trying to define the proximal and distal vertebral artery so that we can put temporary clips there. So temporary clip on the vertebral artery, proximal to the aneurysm and distal to the aneurysm. And my retractor was actually on the aneurysm. Now this is a completely circulating aneurysm, so we decompress. It collapses like a cyst, as you can see it. And we dissect the aneurysmal wall from the brainstem very carefully without damaging it. And multiple combination of fenestrated clips and very large clips to occlude the aneurysm, and we think that we have done it. So you open the distal temporary clip, it is still bleeding. Why is bleeding? Because the fundus is still stuck to the brainstem. And many of these giant aneurysms, you need to exclude the aneurysm, take out, resect the wall of the fundus from the base or from the brainstem where it is stuck before you can completely occlude, as was done in this particular patient. So more clips, and that day we finished all our large, extra large clips. And then now we have taken off the temporary clips, both distal and proximal. Very critical to see that pica is intact, and the ICG, same thing, proximal vertebral and the pica being intact, we can see that. Now this patient was operated in 2007, so it is 13 years now. Last year, actually, he came back unruptured, but every year we used to do angiogram. I don't have, unfortunately, that angiogram, but there is a recurrence of the aneurysm, small recurrence, which we send it to our endovascular colleague for treatment. So this is the post-op CT angio. We've been, as I said, following up every year, and after 9 years or so, she developed some recurrence, and that has been sent for endovascular treatment. Now, this is a young man in his late teens who presented with headache, unruptured aneurysm, and homonymous hemianopia. from this distal ICA aneurysm on the right side. Now, this was actually sent to us by our endovascular colleague because this failed endovascular treatment. And so we went on to treat it by microsurgery. It's a very thick-walled aneurysm. So we have a temporary clip on the proximal to the aneurysm on the ICA, but no clip would sit on that because it's so thick-walled and very turgid. So we are holding with a bayonet forces at the neck to make a neck so that we can put multiple clips. Again, similar technique, multiple fenestrated clips. These are clip blades parallel to the parent artery, first proximal to distal and then distal to proximal. And then we do the ICG. You can see the parent ICA intact, the MCA and ACA intact and nicely pulsating, but there is some residual aneurysm here. But we could not take care of the residual aneurysm without compromising these vessels, part of the anterochoroidal branches. So we left it and we accepted that residual aneurysm because this could be treated now because we have the technique. So we started off this aneurysm and we are left with this aneurysm now, which was sent back to our endovascular colleague. This is before the discharge, mild weakness on the left upper limb. You can see it, which improved over the follow-up. And this was treated by our endovascular colleague without a problem. The last trick in our trade, which we don't do it anymore, this is only 3 patients we have treated such, which is by hypothermic cardiac arrest. Now you can see this is a child, again a child, a 4-year-old child from Bangladesh who came with altered sensorium because they ruptured basilar top. The CT angio was not informative. We thought the aneurysm neck is there, but when you do a 3D DSA, as you can see it here, all the branches are coming out from the aneurysm. So this is the only way we thought we can take care of the aneurysm is by doing a hypothermic cardiac arrest, which we did. We took care of the aneurysm, but the patient child did not improve this one. But I get an email from the parents from Bangladesh that child has started swallowing. He understands, he smiles, but that's about it. Still, we hope is because the child, he may have some improvement over a period of time. We still don't have answer. Excuse me. We still don't have answer to this huge, ugly aneurysm. The whole basilar trunk and the top is diseased, and this acts like a mass effect. We have tried many things, but this we have still don't have an answer. These are some of the example of these serpentine aneurysms which are presenting with mass effect. Many of them over a period of time, they become vegetative or die, and we don't have actually a good answer in our practice. They can probably have multiple bypasses because endovascular treatment also is not very helpful in this kind of things. So this is till July 17, this analyzed by one of my resident, 119 cases of giant aneurysms. Total of 143, but in the new millennium, this till July 17, 119 cases, anterior circulation 99, but significant number again in the posterior circulation. This is how there is distribution there. And what we have done, direct repair in 73 cases, flow diversion and bypass in 34, trapping and flow diversion in 12 cases, ECIC bypass in aneurysms, both high flow and low flow is 38 cases, low flow in 7 cases. We have in this group lost 2 patients died, and our bypass patency in these patients have been 91%. And so I think we compare well with the literature. This is our current series, and this is the literature. You can see the figures in the yellow are endovascular series. So in the literature also, microsurgical series, morbidity and mortality is less comparable to the endovascular series. So I think it is essential to have this technique in our armamentarium, and in our practice we have found skull-base approach, bypass, adenosine cardiac arrest have been very useful. We don't use hypothermic cardiac arrest anymore, and that was the last one where we did about the child. And the technology 3D DSA does help to define, and we have found the adjuncts in the surgery, ICG and fluorescein techniques and microvascular Doppler in the surgery very useful. For the young neurosurgeon, practice is critical, and this is important. So to bottom line in our practice in giant aneurysms, microsurgery and giant aneurysms with a significant thrombus, calcification present with a mass effect, and branches are involved. Endovascular treatment we often take when the patient has an ICA proximal to PKP-COM, but as you see, this is not a panacea. There can still be problem if there is a big mass effect. And when you are just doing parent vessel sacrifice, endovascular treatment is probably the good one to go. So some endovascular, some no treatment, but majority giant aneurysm still microsurgery. Thank you for your attention.
Thank you, Professor Misra. That was very impressive. I think we're running late, so we'll just have one question until we move to...
I can't hear you at all. I can't hear you. You're muted.
No, I'm not. Can you hear me now?
We are hearing you, Dr. Amr.
Yes, but Professor Misra cannot hear. Can you hear me now, Professor Misra?
I can't hear anything. Hello?
Hello?
What happened?
I'm hearing you.
احنا سامعين حضرتك كويس دكتور عمرو، هي غالبا المشكلة عند الدكتور.
There is some problem. I can't hear.
Have you stopped sharing the screen?
Professor Misra, we are hearing all of the participants and audience. I think there is a problem. Please check your...
Hello? Dr. Misra, can you hear now?
Okay, let me, can you hear me? Can you hear me?
Yes, yes.
Okay, then let me leave and come back. I think there is some problem. Let me come out and come back. I think you can probably take the next speaker, Professor Osama. I'll come back. Okay, I can't hear anything.
So we'll have to move for the sake of time. Now we have Professor Osama El-Ghandour. He's Professor of Neurosurgery at Al-Azhar University, Honorary President of the Egyptian Society of Neurosurgery, and former Dean of Al-Azhar University. And he's going to give us a talk about management of giant aneurysm. Dr. Osama has a vast experience in skull base and vascular neurosurgery, and we're all eager to listen to.
Thank you very much indeed, Professor. And I must thank all of you, especially organizing this webinar. And also we shouldn't forget to thank Professor Basant Misra, who's a great friend of mine for 20 years. And Eva Farm always supporting these medical educations. Now we'll start with the management of can you see it's evident now?
Yes, sir.
Okay.
It's working.
Yes.
Well, I'll start from the basic for very simple things, because in our society, aneurysm in general, they are not that common as used to be. But we must remember that the difference between a normal arterial wall and an aneurysm wall, the aneurysm wall is always thick. The aneurysm wall is very thin and weak and liable to rupture. The exact etiology, we can't say, is it a real congenital or from hypertension or trauma or embolism or infection? But what we noticed usually it occurs at the bifurcations or the branches. Why? Because the internal elastic lamina is deficient. You remember that in embryologically, the arteries, they come a tree by uniting. So at the site of uniting of the branches, there is always defect at the internal elastic lamina. We don't see them very much in childhood. And in Egypt, I'm afraid we are lucky really to have very low incidence of aneurysm, not more than 10%, which is very good for the hazardous patient. Hemorrhage is more greater in females. Smoking, alcoholism, hypertension also increase the risk of bleeding. But we must know to differentiate. Sometimes you cannot differentiate between a minor ictus of bleeding and infarction. Hemorrhage always occurs during exercise activities, during walking, running, emotion, outrage, emotional, and during sex as well, or constipation with massive training. We must remember that sadly, about only 35% of cases do not come to life back to normal life. They have always deficits. So we can't say we are saving them totally back to normal. And up to 30%, they don't reach a hospital. They die at home or on their way to the hospital. It's a very simple thing we don't need to go about. And this I mentioned that the adventitia internal elastic is very thin in aneurysm, and the internal elastic lamina is very thin. The musculosa also is very thin. Hemorrhage could be a classic, which everybody knows, or could be small, but we must know that the hemorrhage in the subarachnoid space in 70%. It could be intracerebral or intravesical, wherever, and the volume usually not more than 1 to 3 centimeters, but sometimes severe and fatal up to 100 cc's. The time of bleeding, people may not understand that the time is not too long. It's just 1 to 2 minutes. And then the natural mechanism comes to stop the bleeding, like tamponade, vasospasm, retraction, and thrombosis. Aneurysms might have a daughter aneurysm or blip, or what we call it the nipple-like aneurysm, which is always the source of bleeding, and usually at the sac or the fundus or the sac terminal there. And the wall is so much attenuated, and sometimes when you look at the microscope, it's transparent. You can see the blood inside. Sometimes it's hyalinized in giant aneurysm, even calcified, but this is very rare. Aneurysm might have a very broad neck, which is very bad. You need to reconstruct or make what we call aneurysmography, or to restore the normal stream of the parent artery. Sometimes the aneurysm have many perforators or branches which comes through the sac, and this is more also difficult. The aneurysm usually associated with high morbidity and mortality, and about 8% die from progressive deterioration after the initial hemorrhage, not because of bleed, mainly from spasm, infarction, edema, and sometimes to rebleed in this early, very early. Mortality is doubled in the second bleed and folded or become more exponential by the third or fourth bleed, and so on. So the natural history of aneurysms, that's why we treat aneurysm. Why we do treat aneurysm? The first bleed, it just passed away. But because if you look at the natural cause, they keep bleeding and rebleeding. And the more they're bleeding, the more serious and more dangerous and high mortality and morbidity. Anterior circulation aneurysm is far common than posterior circulation. And usually it's about 85%, and posterior circulation is only 15%. Multiple aneurysms and mirror image aneurysm means the same. You may see just up to 20 to 30%. You may see both aneurysms, like we call it mirror image, to a posterior communicating artery aneurysms, or MCA, middle cerebral artery bifurcation. You see it on both sides, exactly like a mirror. But you must know that the Japanese have the highest incidence. It's different from other things. And they have vertebral basilar aneurysm more than or equivalent to the anterior circulation. And they have higher incidence of multiple aneurysms. And also, it seems that something congenital, because the aneurysms, they don't happen at the bifurcation or the branches of the artery, but also occur at the artery itself, and also with a wide-based neck. And if we look in adult age, the aneurysm constitutes the highest incidence of bleeding. And if you look at the bleeding post-mortem, the angle brain, it starts in subarachnoid and goes around. And clinically, why I'm just should pay some attention to that. Everyone knows the classic one, which is the 65%. Everybody knows that's classic one. But the minor hemorrhage, which is sometimes constitutes 15%, mild headache and pass like flu without even neck pains. And this first bleed might be missed by the patient and the physician. And when they present with second bleed, they mistaken as a first bleed. This is the serious part of it. Fatal hemorrhage occur in 25, and these the ones which I talked about. They don't reach the hospital. They die before they go. The classic, we call it the bang. Bang means as if you bang, you stroke, and abrupt and punctual. Punctual, and I always, when you take the history of some patient, I say punctual. What's meant by punctual? Punctuate means very localized. The patient can describe the exact minute or second what was he doing. They say, I was talking in the middle of a lecture. I was sleeping with my wife and just about to have ejaculation, and has this happened. It's something bang it is. And there was an emotion and emotion range at the end. So that's what's meant by punctual, because if you don't know that, because migraine has headache, meningitis produce headache, lots of causes for headache, but the classic subarachnoid is always punctual or punctate or bang. Of course, nausea, vomiting, neck stiffness, drowsiness, and neurological deficits, whether hemiparesis or dysphagia or subhyaloid hemorrhages. And we must remember that the neck stiffness in the first few days, and then as the blood trickles down from the subarachnoid space, the base brain, down to the interscapular, then down to the lumbar region, a patient after 10 days, he may have even backache because of the trickling of the blood downwards. So we must follow and know what's happening. This is an example of subhyaloid hemorrhage. Clinically, unruptured giant aneurysm. Sometimes they are discovered incidentally without hemorrhage. And sometimes, which is the commonest here, they present as a mass effect, as a tumor. But the difference between tumor and aneurysms is that the symptoms are fluctuating. They are not progressively deteriorating or producing deficits. For example, posterior communicating aneurysm producing 2/3 or 6 nerve paresis. Anterior communicating aneurysm, giant one, leads to optic apparatus or field defects affection. Vertebrobasal leads to ataxia or 6 nerve paresis, bulbar palsy, and so on. Middle cerebral arteries sometimes give headaches, seizures, and infarcts. So, but the point to differentiate between a mass, a true tumor, and aneurysm is the fluctuation of the course. The patient said, I'm okay, I have nothing now. And last week I was having severe headache and my third has ptosis and so on. And now he is okay. So on and off. And for example, if you compare between pituitary tumors and due to pituitary adenoma and giant anterior communicating aneurysm, you see the patient has scotoma or bitemporal hemianopia, and 1 week later he has nothing. This aneurysm should make you to rouse the possibility of aneurysm, but with a pituitary adenoma, no, the progression is always there. They don't improve, even they become worse. Aneurysm of vein of Galen, as this is a congenital status, we see it sometimes. It's very rare, and clinically it presents in babies with large head due to hydrocephalus, or sometimes with heart failure due to high cardiac output heart failure. I mean, when we look at the grading or classifications, many classifications like Hunt and Hess, which is, I take it myself as the best because clinically, mild headache, second degree, most of them are more or less the same, but Hunt and Hess, Fisher classification is according to the blood and how we differential diagnose of aneurysm. Is it AVM or idiopathic hemorrhage or pituitary apoplexy or hemorrhagic tumors? I remember a case being shifted to me or sent to me as a pituitary tumor. And in fact, it looks blood in the pituitary star, but localized, and it turned out to be a huge or giant anterior communicating aneurysm. So pituitary apoplexy, one of the mistakes, because they have severe headaches, they have visual obscurations, and hemorrhagic tumors also might be. AVM, we usually see it in young children. As a diagnostic point, CT is very sensitive for blood than MRI, even in minor hemorrhage, but provided that you do that very early in the first 24 hours. It's positive up to 99%. So if you wanted, that's why before deciding your incision, that's infarction or so on, so you should do CT scan to see the blood, especially in the first 24 hours. And sometimes it's a giant aneurysm, it vividly enhanced like an artery, you see the aneurysm very big. You can suspect the aneurysm from CT scan by the location of the blood, by the spasm, if you see it, and you can see. And nowadays, the helical and 3D CT scan can show you the aneurysm clearer even than angio, and show only the inside of the aneurysm, if it is really calcified or thrombosed, or as you can see, good have a knowledge about the inside of the aneurysm. Fisher classification, which depend on the amount of hemorrhage, as you see, MRA and MRI, useful, but still you cannot really depend. Conventional MRI, angio is the best to tell you. And the rule is 4 vessels angiography. Why 4 vessels? If you know this patient has middle cerebrum, has fits, and has the right-sided hemiplegia and dysphasia, but because he might have mirror image. Why we do it again? Because if you may miss multiple aneurysms. This is very important. And to see the spasm, and the spasm might be very localized around the aneurysm origin, or it takes the whole the circle of Willis. Sometimes when you do angio, you don't see the aneurysm, you see only spasm. So you need to re-angio in 4 weeks time to see that. I mean, if you see multiple aneurysms and incidental aneurysm, how do we decide where is the offender? Which one, which bled? I'm not expecting to see all these multiple or mirror image aneurysms, both of them bled. No, usually one of them bled. So it takes the history and the clinical manifestation. One was dysphasia, I would expect that. One was visual obscuration, I would say this anterior communicating. One was some ataxia or third nerve, I would say basilar artery or posterior communicating aneurysm. And angiography will tell us by being number 1 is the largest one and have more irregular contour with a blip or daughter aneurysm. This is the one which bled. The one which has spasm around him or near it. And the proximal one, if we have 2 aneurysms on the same artery, the proximal one is the offender one. I'll show just a few examples of classic hemorrhages in the CT scan. This is called the pituitary star. Pituitary star, where the arachnoid surrounds the pituitary gland and the interhemispherical fissure and the sylvian fissure and the cisterna ambiens. All these show you that. These examples again of large and ruptured aneurysm. I wouldn't take much time about that. Multiple and different types of giant aneurysms here. Multiple aneurysm, severe hemorrhages, aneurysm again, internal carotid artery in the cavernous sinus inside there. Giant aneurysm there, partially thrombosed, and some of them thrombosed like that one. This one probably thrombosed. Aneurysm again, you see, sometimes you see that, mind you, we don't see that every 4. I mean, see, if I say, in my humble experience, I'm not just probably 3 cases per year. So all the cases are collected over 30 years or 40 years. So anyhow, we don't see them much, or probably this patient came because of this lipoma, not because of the aneurysm. He has ataxia and he thinks that this lipoma is the cause of his problem, but as you see here, has a big vertebral-basilar aneurysm. Again, basilar aneurysm, this one to dissect, but I don't think it will work, this video. Another example of giant aneurysms there, huge aneurysm. Look at here, this aneurysm here and there, and there. And I must say, I should thank the people of the interventional because they took the hassle of surgery. They took the burden. We had enough brain tumors and other cases to work, but they're doing very well, and the learning curve is very good. Examples of giant aneurysm again, aneurysm multiple, look at that, and aneurysm again, huge aneurysms again. And you must also remember that we see with anterior communicating aneurysms, it's always, not in fact always, the A1 of the opposite side is absent. And this makes you to be very careful in applying the clip exactly on the neck, because if you exclude the A1, you will kill your patient because there is no A1 from the opposite side. Definitely will have paraplegia because you're including both anterior cerebral arteries A2s on both sides. And this anomaly or this spastic or absent A1 from the opposite side, always careful that you have to protect the side which the aneurysm is giving. Sometimes you see the aneurysms with AVM, not just AVM and aneurysm here as well. Look at that, and this is a big, giant posterior communicating aneurysm, and this as well here, another one. Different types of aneurysms, funny things about it. And again, look, anterior cerebral artery A1 is absent here. So we have to be very careful about it. This bifurcation aneurysm, different types of aneurysm, digital subtraction aneurysm, multiple aneurysm. I think you've seen that. In fact, I must thank Professor Basant Misra because he took the hassle of surgery and the techniques. But I wanted to stress the clinical and how to diagnose, which is the most difficult part of the problem. This is an example of aneurysm of vein of Galen. Look at that, which we see in children, huge aneurysm of vein of Galen. And look at that, when you do the angio, look at the straight sinus, blood dilated, aneurysm of vein of Galen. What do we do? I think I'll talk about the timing of surgery. If we say, ideally, I should, the early is possible, but it's not always applicable. Early surgery, why people or surgeons prefer, because the risk of bleeding as you wait is coming. So immediate clipping is far better, but early surgery also stop the vasospasm, which happens on the 6th or 7th day, and arterial hypertension there. Early surgery also allows washing of the blood from the subarachnoid blood, which is a factor in initiating the vasospasm. Late surgery is preferred because it's easier, I must say. The clot will be liquefied, easily shrunk, brain now become not angry, slack, and inflammation is less, and the risk of intraoperative rupture is not higher as in the earliest one. The vasospasm also is less. So, but sometimes we are obliged to wait for delayed surgery because the poor medical patient, he is dehydrated, cachectic, diabetic, hypertensive, you need to adjust all these, or has marked bad Hess and Hutt classification grade 5. And you know, sometimes difficult because the soon necessitating lax brain to make things life easy during retraction and maneuverability. The edema also will appear. Anterior circulation aneurysms usually clipped through trional approach, or some people do. But nowadays, is you do it with endoscopic assisting from trional. Posterior circulation, if it is in the basilar tip or higher basilar, you go subtemporal. Again, you can do trional. But if it's low down in the vertebral, or low in the basilar or vertebral, you go the suboccipital approach. The golden star that you trap, you exclude the aneurysm from the artery. But this is not always easy. You can do, these are different types of clips and applicators or appliers, but temporary clips, they are golden, and they are softened kind for the arteries. Permanent clips sometimes are fenestrated to allow the passage of the tumor. Sometimes you do trapping in the past time, then you do, as an addition, you have to do anastomosis between STA, superficial temporal artery anastomosis, and MCA artery, medicine artery, especially if you trap or you occlude the parent artery. In giant aneurysm, usually, if they are too large, but in our country, forget about what you see in the literature. Sometimes you see an orange size aneurysm or a big lemon size aneurysm. In giant aneurysms, when you operate or you treat it, you have to excise it, because if you don't take it, it will remain act as a mass. You are not expected to disappear by time. You have to excise, you evacuate it, and you cut the sac and leave the clips in place. Clipped carotid artery bifurcation is an example, a scovial, very simple projection. And this is a posterior communicating artery aneurysm, as you see, a giant one here. And when you put it, it disappears, and this is a patient. Another example of a giant aneurysm, you put the clip there. What are the complications? Intraoperative rupture. And trouble, if this happens, you need not really to do cardiac arrest, but you need to lower the blood pressure back. And we have what we call a second sucker called the snake. The snake, which is not a rubber sucker, which suck quickly the blood, so you can see and apply the temporal clip on the parent vessel. But you must not damage the cranial nerve or obstruct the venous drainage, because this will lead to more angry brain, more swelling of the brain. You have to be calm, and then you put the temporal clip for the intraoperative rupture. And the wide rupture, we must say, by blunt bad dissection, you always use sharp dissection. And when you dissect, the tip for the junior staff, play around the neck, go far away from the fundus or the sac there. Look at the parent artery and the neck. And when you clip it, look for the rest of the aneurysm, the sac and the fundus, but not from the start. If you play around the fundus or the sac, the aneurysm will rupture to area premature without seeing the parent artery, and you will be in a great mess. So be careful about that. Post-operative care, absolute rest. Sometimes you need to make hypertension. I usually give anticonvulsants, and we follow up angiogram later on. And during surgery, sometimes we used to give nimotopidine nowadays, but in the old times we used to use papaverine. I don't think you remember for the juniors. Papaverine we used to put intraoperatively to help and to prevent post-operative spasm from manipulation of the parent arteries. Wrapping really should not be used nowadays. I mean, this old technique. And how do we treat vasospasm? As I mentioned, hypertension, but not too high, nimotop or nimotidine, antioxidants, and during surgery or papaverine. What are the complications of aneurysm? Rebleed, vasospasm, hydrocephalus. Why you have hydrocephalus? Because of the junk and the blood in the arachnoid space will close the sternal ambience and produce hydrocephalus. It might happen weeks or months later on, so not to be surprised to see it. Of course, diabetes insipidus and inappropriate ADH, you might see it with giant aneurysm or aneurysm near the anticomp, where is hypothalamus there, DVT if the patient is bedridden and had pulmonary complication, deficits, and post-operative infection there. Non-surgical, which is not our domain, we thank the endovascular people, which rarely takes the hassle. I must be honest with you, nowadays, I mean, especially in the past 5 years, if I have aneurysm, I send it to the endovascular. And if he say, no, I can't do it, I take it back and they do surgery. So I always ask myself, if I myself have an aneurysm, do I treat the puncture in the thigh or craniotomy in the head? So long we have a good, competent endovascular man who can deal with that. Why don't we send it to them? As I mentioned, if they do it well, they have a good learning curve nowadays. So they use whatever detachable coils, chemical or mechanical. These are examples of coiling again here, and I thank you very much indeed for your kind attention.
Thank you, Professor Osama, for this comprehensive delineation of all the aspects around aneurysm and joint aneurysms. And I think we're still running short of time. So do we have someone? I think there's an announcement by Eva Farm. They should be doing this now. Do we have someone from Eva Farm now?
Yes, Dr. Amr.
Yes, please.
Do we start now?
Yes, sir. You have 2 minutes. Yes.
Oh, okay. I'll just highlight about a new hope for nowadays. Everybody is asking about what are we doing as a pharmaceutical industry and Egyptian pharmaceutical industry to treat or to act or to have rule in fighting against COVID-19. I'm asking if you can see the screen I'm sharing.
Yes, we do.
Yes.
Dr. Boulos, can you please share full screen slideshow?
Okay. I would like to congratulate all the Egyptian people about taking the license of 2 products Eva Pharma will launch to fight against COVID-19. The first product I think you hear about, his name is Remdesivir, and we are the first Egyptian pharmaceutical company who will produce this product or will take the license among 3 pharmaceutical industry all over the world. Eva Pharma will took the license to produce and to export Remdesivir to 127 countries. We are all proud of this success. And the other product, of course, Remdesivir for the moderate and severe cases, while the other product called Avipiravir for the mild cases, we also took the license, but not produced yet. I would like to congratulate you all. This is the first picture showing that we already give Mustashfa Asr Aini hospital Remdesivir. This picture also for Ain Shams Hospital, Ain Shams Al-Takhassusi Hospital also received Remdesivir yesterday. So I would like to congratulate you all about this new hope and the actions really taken by our pharmaceutical company Eva Pharma. We are the
بعد إذنك برضه الأزهر غلابة
And of course, Dr. Osama. Yes, no. I would like to tell you that we are giving all the hospital needing, and if the Azhar hospital need, I'd like to ask you to send me.
Excuse me, Dr. Boulos. I would like to inform Dr. Osama and all our professors that the first batch, around 1,100 vial, was given as a donation for all hospital staff, physician, nurses, or يعني as we said جيش مصر الأبيض يعني.
عندنا 3 دكاترة ماتوا.
احنا مش متاخرين يا دكتور، احنا we are fighting فعلا. احنا يمكن من الشركات القليله يمكن اول شركه. انا مش بتكلم كده عشان انا I'm working in IFA Pharma, but it's a great honor and we are in the first step fighting this COVID-19, and I would like to tell you about the huge and extra effort done by our CEO, Dr. Riyad Al-Manyous, to be and the first produced product is given to the Egyptian doctors, physicians, and nurses who really needs this product. So this is not a promotion as much as it's a facts and an action really taken by our company. In few minutes, I would like to highlight our product Ancilocox. Etoricoxib 60 and 90 milligram. It's an anti-COX-2 inhibitor. Ancilocox or Etoricoxib was taken the European Medicine Agency approval, and it was the benefits of Etoricoxib containing medicine overweight the risk when used in treatment of rheumatoid arthritis and ankylosing spondylitis. This was the license in 2008. This slide shows the bioequivalence study of Ancilocox versus the brand. This study is almost asked by every new product to show the bioequivalence study versus the brand. This slide shows that the two curves are similar to each other, which reflects the high quality procedures taken by IFA Pharma among all its products, and Ancilocox is one of them. Ancilocox provides 3 benefits to your patients. First of it's 1 tablet daily, high compliance, safety on GIT, and cover the 24 hours. Ancilocox had 2 packs, 60 milligram and 90 milligram. For the 60 milligram, each 10 tablets, each strip price is about 49 Egyptian pounds, while the 90 milligram, each strip price is 52 Egyptian pounds. I would like to highlight this study that shows that Ancilocoxib versus diclofenac as a potent effect, as analgesic effect. This study shows that Etoricoxib 60 milligram has similar effect to diclofenac 150 milligram. In the treatment of patients of osteoarthritis, this shows that Etoricoxib is really potent non-steroid. About the safety of Etoricoxib or Ancilocox, this study shows that efficacy and safety of Etoricoxib compared to naproxen 1000. This shows that the Etoricoxib safety or the Ancilocox safety was for 138 weeks, almost 2 years and a half, which is a marvelous effect to use non-steroidal for 2 years and a half without any complication concerning the GIT safety. Finally, this study showed that our product Ancilocox 90 milligram used for the treatment of patients of rheumatoid arthritis compared to naproxen 500 milligram twice daily. This shows that Etoricoxib or Ancilocox was generally well tolerated in all rheumatoid arthritis patients. These are recommended doses for our product, and Silacox, this is the maximum recommended dose. These doses are the maximum recommended dose. The maximum recommended dose for osteoarthritis is 60 milligram daily. The maximum recommended dose for rheumatoid arthritis, 90 milligram daily. For ankylosing spondylitis, 90 milligram daily. For acute gouty arthritis, 120 milligram daily for 8 days maximum. I would like to thank you and would like to thank the Egyptian Society of Neurosurgery, Dr. Nasser El-Ghandour, and all the staff. And it was a great honor to be with you today. Thank you.
Thank you, Dr. Bolus, for this. This is a very important information, and thank you for that. So back to Dr. Misra. Again, Dr. Misra will be giving us a second and last lecture about decision-making in giant AVMs. I know that there are lots of questions, so we'll try to gather up most of it before Dr. Misra leaves us at 4 because he has another obligation.
Okay, thank you again. Good afternoon. This talk would be management strategy in cerebral AVM and decision making. Okay, as we all know, in cerebral AVM, there are many options we have today. The observation, a large number of AVMs today can probably be observed without any intervention. And these are the other options which are available, and multimodality treatment. And the last part, my talk will cover a little bit about the Aruba multicentric study. This is based on this personal experience. We were the first gamma knife center in my country, and in fact, South Asia. We got the gamma knife 97. So I get a lot of patients referred by all of the other neurosurgeons. And so this is my personal experience of microsurgery in 234 cases and radiosurgery in 392 cases. Now, in our practice, we prefer microsurgery in patients who are young, who have small, medium, size nidus, and it is an accessible location. Now, accessible location, I put it in quotes because each surgeon has an accessible location, because depends on what is one's experience. Somebody who is very experienced may be able to take out many AVMs, whereas a beginner may not be able to do it. An AVM which is associated with aneurysm and which presents, of course, with hemorrhagic presentation are better candidates for microsurgery because it gives immediate and complete protection. AVMs which have venous outflow obstruction or a single draining vein have a higher risk of hemorrhage. Again, they are also better candidates for microsurgery in our practice. Now, I give you some examples. This is a small AVM in the motor cortex, sensory motor cortex on the right side, presented with hemorrhage, as you can see, intraventricular hemorrhage. So appropriate candidate that it is taken out because a small AVM and at the best removed and with a complete protection as was done in this patient. This is a left side, little more difficult, complex, eloquent cortex AVM of the left side, sensory motor cortex. Again, young man presented with hemorrhage. We excised it microsurgically. As you can see, immediate post-op. These are the clips there, the scalp clips. You can see the artery is still prominent. Artery remaining prominent immediate post-op is not a significant concern. However, if you see an early draining vein, that would suggest that there is residual AVM. Now, these prominent immediate post-op artery, prominent artery in the immediate post-op DSA usually goes away over a period of time. This is suggestive of hyperdynamic circulation, but it is critical that all AVMs should have a post-op check DSA as opposed to small saccular aneurysm, which can probably be followed by a CT angio, because DSA is critical both before and after excision to have a complete cure. Now, another motor cortex AVM, small one, again with hemorrhage, treated microsurgically. Basal ganglion AVM with hemorrhage, again treated by microsurgery, both pre and post. This is a posterior post AVMs. Again, if there is blood, we would prefer surgery as was done this particular patient, supplied by PCA and superior cerebellar artery, and the post-op complete excision there. Now, what about AVM surgery without this DSA? Sometimes we do it, especially in patients who have presented with a large hematoma. We don't give time. Or sometimes we have a small compact AVM, which is very nicely seen with the newer CT angio with a 3D CT and is a small AVM, especially in countries like ours where the second study sometimes is expensive. We try to avoid that. And this is one such patient who presented with hemorrhage, massive hemorrhage. We excised it completely microsurgically, and based on this CT angio, we didn't do a DSA preoperatively, but always we do a post-op DSA to confirm that there was a complete excision. The aids in our microsurgery in our practice, what we have found when there is a small AVM, especially in eloquent cortex, is very important to have all the evidence, even investigation you have, like a functional MRI, neuronavigation, DTI. The problem with small AVM is localization and complete excision. In large AVM, these problems are different, but small AVMs also you can miss it. So it's important, and you can, if it is a motor cortex, eloquent AVM with a bleed, then you need to have the functional MRI. So we do functional MRI, neuronavigation, DTI, and intra-op neurophysiologic monitoring, both SSCP and MEP. I'll show you an example. In large AVM, the problem is bleeding is very significant. So we do in large AVM pre-op embolization, especially with Onyx. We find it useful. There has been some discussion, controversy about it, but in my practice, we have a very good endovascular surgeon with us. So we do that. And large AVM, we use induced hypotension. This is one of the very few surgeries in vascular surgery where you use induced hypertension both during surgery and after surgery. Unlike in aneurysms, today we don't use hypertension in aneurysm, which we used to do 20 years back, because to avoid risk of vasospasm in the post-op period. Another critical instrument in my practice is a non-stick bipolar forces. Very, very important instrument. If you have to choose one instrument which is critical for your surgery, it has to be a non-stick bipolar, and one has to have a number of bipolars. Non-stick bipolar, we have this non-stick bipolar which are actually disposable, but we use it repeatedly. But these can be, tips can be changed, and we use it. And as opposed to aneurysm, where ICG and fluorescent video angiography are much more useful, that is not so much useful for checking complete excision in AVMs. Excuse me. Complete excision of AVM can only be checked by DSA or check angiogram intraoperatively, because ICG and fluorescent VA only shows what is under the microscope. So part of the nidus which is buried inside, away from the microscopic field, you can still miss it even if the ICG does not show you. So that's the fallacy of ICG in AVM surgery. Now this is an example of very tiny AVM which presented with bleed, and it's a motor cortex AVM. So we do fMRI, tractography, and you can see this is the motor cortex, and this is the AVM, and that is the leg area, that's the hand area. So we define that before going for surgery. And this is another young girl, 14-year-old, who presented with bleed and seizures, had multiple embolization in the past, but nidus is still intact. You see the tractography, that's the hand area, that's the leg area, very adjacent to the nidus, and that's why she had right lower limb weakness. So we do the MEP, we have defined the motor cortex. That is the motor, that is the sensory. We are stripped to reversal of the SSCP in the reversal, and then under awake craniotomy, we define the motor cortex. And you will see that now this is the ICG. You can see this is the feeding artery. Now we put the grid, and that is the motor cortex. That is the sensory cortex. Now we are trying to stimulate the motor cortex. Now you can see that. So you can see that the tonic-clonic movements of and that defines the motor cortex. So we spare the motor cortex and we open up the we sulci, transsulci approach. We go inside the sulcus, dissect it out, and reach the nidus and excise. And this is very, very important, very careful going around the nidus without damaging the surrounding cortex, because it's a motor cortex AVM. So we excise, go around it, and we see sometimes we have to decide whether it's an artery or a vein. So we put temporary clips to see whether the turgor decreases. And you can see this is defined, this is an artery. And so we have to clip it and take it out and coagulate. So we go around it. And in between we use temporary clip. In between, if you have a doubt, we stimulate again. And we spare the vein to be taken out at the end. First, we take out all the arterial feeders. And this, of course, it has to be excised in toto. You can't take out in piecemeal in AVMs. So we go around it circumferentially. And once we have taken off all the arterial feeders, we occlude the vein, and that's the vein taken care of, and then we cut it. And the last vein, draining vein, we are cut. And we excise. You see very nice bed, the undamaged brain there. So that is what we need to do it. And now sometimes we have done staged embolization and staged microsurgery. This is a patient, again, high flow AVM, as you can see it, 2-stage embolization, and then we excised, but it took a long time. So we came back after a second stage and removed the whole thing. Now, embolization, partial embolization is no protection, and there is a false sense of security if you do a partial embolization, and the patient can even bleed after a few years. Now, this is the patient who had embolization 5 times, but had a hemorrhage, and then this again a motor cortex AVM you can see, and then we excise with a total excision there. Total excision is the only thing which gives cure. Now, this is another pre and post of post embolization. You can see that residual AVM there, but the turgor has decreased, the nidus has decreased, and then we excise with a complete excision by this immediate CT angio and follow up post for DSA. Now, as I said, partial embolization has no protection, and this is a patient who was partial embolized, a very complex AVM, bled after 10 years. So this has to be kept in mind. Partial embolization patient have to be advised, follow up treatment either with microsurgery, radiosurgery. So this was we actually gave gamma knife, which failed, and so we have to have all the modalities with you, and then we gave we excised with microsurgery and had a complete excision and cure. So in our practice, we do prefer radiosurgery when the AVM is in the deep location, have a deep venous drainage, and eloquent cortex, elderly patients, and especially in non-hemorrhagic presentation. I'll give you some examples. Now, this is a high flow diencephalic AVM. As you can see, that looks big, but mostly the varices are there. The nidus is amenable to single stage gamma knife, which was done. This was an unruptured AVM, and you see in 2 years complete resolution of the nidus, and this is an excellent treatment with whatever microsurgery we can do in the best of hands. There are risks involved, so choosing the right patient for the right treatment is the way to go. Similarly, in the splenial AVM, posterior corpus callosal AVM, if he has not bled, again a good treatment is the gamma knife, which was done for this particular patient. And this is a thalamic AVM, again appropriate for gamma knife, very high risk for microsurgery. And this is a thalamic AVM which had bled, and so we get gamma knife, again a complete resolution of the AVM. And this is another thalamic AVM, a little bigger, so it's a partially embolized by onyx, and then a gamma knife, or the residual nidus was gamma knife, and 3 years down the line you can see complete obliteration of the nidus. Now, sometimes combined treatment, novel treatment, very few cases we have done like that. This is a lady who presented with hemorrhage, and this was we treated in 1997. And this had multiple aneurysmal varices with a nidus, and we took off all the nidus, the aneurysmal varices by the microsurgery, but the nidus was supplied by perforators of the choroidal, which we thought was too risky to go for microsurgery. So this nidus, small nidus, was treated with gamma knife, and this is a very, now it's a 20 years, I think in 97 we treated it, now remains completely occluded without any deficit. So it's a combined microsurgery followed by gamma knife. Now, how long one waits after gamma knife if the nidus has not gone completely? Now, if the nidus has significantly reduced, Like in this, there's a big nidus which reduces after 3 years, we follow up. If you are significantly reduced, then we follow up for 1 more year. If there is no reduction of the nidus for 3 years, then we think it's a failed treatment. But most of the time, if it has not gone away in 4 years after gamma knife, then we call it a failed treatment, and then we would go for adjunct, again second gamma knife or surgery depending on the location. A novel treatment, again, a very large nidus, grade 5, Spetzel Martin, eloquent cortex. These are difficult cases, and sometimes you probably don't need to do anything, but if you had multiple hemorrhages, then one way of doing it, we have few number of cases, and this is an advice which been given by Pittsburgh group, we staged gamma knife. So first stage and then repeat stage after 6 months, and you can see significant reduction. But occlusion rate, cure rate in 2-stage gamma knife is only 50 to 60%, as opposed to in a small nidus about 80%. And we have in our practice relative contraindications for gamma knife when there is single draining vein, venous aneurysm, venous restricted disease, or intranidal or pedicular aneurysm. All these factors increases the risk of bleeding while waiting, because there is a latency period after gamma knife. It takes minimum 2 to 3 years, and during that time the patient can re-bleed. So if you have any of these factors in the DSA, we would prefer for a microsurgical treatment if it is possible. Now, what about timing of treatment after hemorrhage in an AVM? As opposed to aneurysm, where we would like to go in as soon as possible, in an AVM, we would like to wait unless it's an acute or a life-threatening hemorrhage. Acute also in hemorrhage from associated aneurysms. Otherwise, we wait for 2-3 weeks if you are going for microsurgery, because the brain becomes lax, there is not a swollen brain. So unless it's an emergency, we would like to wait in AVM for microsurgery. If you're planning for radiosurgery, we usually wait for 2 to 3 months before we do gamma knife radiosurgery. Now, our gamma knife, as I said, we have more than 300 odd patients now, but this is until December 2006. One of my residents analyzed 190 consecutive patients which were treated by gamma knife for between 10 years, 97 to 2006. Follow-up of more than 2 years was available in 96 patients. And in this group, there was complete obliteration of about 83% of patients. And unlike in the literature, we did not find any difference in the outcome depending on the volume, margin dose, prior embolization, or hemorrhagic presentation. That's a little unusual. The outcome after gamma knife in this series, the patients, 3 patients had new onset seizures. In the latency period, 2 patients bled, and for post radiosurgery, 2 patients developed focal neurologic deficit. One was a worsening of the pre-existing deficit, and second patient had a new onset of focal deficit. These were both were motor cortex AVMs. We have some concerns when we do gamma knife. The success rate is not as high as microsurgery in the best hands. Microsurgery, we have a cure rate of 90% plus, and in the best modality in radiosurgery is about less than 85%. There is a latency bleed, as I talked to you about. There is a risk of edema, late cyst formation, and post-occlusion hemorrhage. The nidus has completely gone away, but the patient can still have a bleed. Very unusual, but does happen. I'll give you some examples. Post gamma knife is a motor cortex AVM, unruptured. We treated by gamma knife. You see MRI, significant edema. More often than not, MRI looks very, very dangerous and horrendous, but the patients are not that bad. And over a period of time, you need steroid treatment, but for a long time, 6 weeks to 3 months, and they usually get better with time, but they can have deficits. Now, this is another patient which we had treated by gamma knife. Is again left side motor cortex, speech cortex AVM, and this patient had complete occlusion of the AVM after 2 years. Came back after 4 years with this hemorrhage. We thought maybe there was some AVM which had left, but we did a repeat DSA. Again, there was no nidus in the DSA, high quality, but there was bleed. So there may be some, there was paucity of vessels, as you can see, but there was no nidus. So these are probably microangiostructure changes which produces bleed. Nobody knows exactly what happens. It's a very small percentage, but it can happen. One has to be aware of it. Now, what about endovascular option? In our practice, we use it as an adjunct to microsurgery, very rarely before radiosurgery. If a volume is amenable for single stage radiosurgery, we do not advise pre-radiosurgery embolization. In fact, there is literature does suggest that AVMs which have been embolized and has gone for radiosurgery, success rate is lower than patients who have been treated only for radiosurgery. So if the nidus volume is amenable for single stage radiosurgery, we do not do embolization pre-radiosurgery. Sometimes palliative, very unusual, especially very high flow AVMs, patients who present unruptured, patients with headaches or cognitive deficiency or hydrocephalus can be reduced, the nidus can be reduced, the flow can be reduced, may give some relief, but does not cure the patient. Unfortunately, endovascular option cures only 10 to 20% of AVM. So the first line of treatment in this patient is microsurgery. Now, this is in our practice, as I said, we use AV embolization as an adjunct to microsurgery. This is one example of basal ganglion AVM, partially embolized and then excised completely. Now, embolization before radiosurgery, we very rarely do it unless there is an associated aneurysm which has not bled, large AV fistula, large nidus occasionally. Now, this is an AVM which had bled from this AVM, but this aneurysm was there in the depth. We thought that this is best treated. It's a distal vessel aneurysm and difficult to localize. So this was treated by embolization, endovascular option, and this was treated by gamma knife because this is eloquent speech cortex AVM. Now, some endovascular people are advised pre-radiosurgery embolization for AV fistula in AVM. We don't think it is necessary. AVM actually, as for definition, are multiple primitive high flow arteries connected directly to the venous system without an intervening capillary. So every AVM have fistulas. So it is not necessary to treat it. Embolization before microsurgery, we do it in high flow AVMs, large AV fistula and large nidus. In our practice, we find it is an advantage, less blood loss, no blood transfusion in many cases, it shortens operative time, and it reduces the risk significantly of perfusion pressure breakthrough, especially in a high flow AVM. So we do use embolization as an adjunct before microsurgery. But not all cases of AVMs we do, and this is a patient in late 60s who had this AVM with a large varix. Patient had a multiple comorbidity, ideally should have been operated, but he was not fit for anesthesia. And this patient had actually had a gamma knife for the small nidus. And lo and behold, the whole nidus went off and the varices also disappeared. Unusual, but does happen. Many of these patients, as I said, today in our practice, we do observation in thalamic basal ganglion AVM more than 66 centimeter. Most brainstem AVM we do not treat today. Elderly patient with spectral Martin grade 4 and 5 in convexity, we don't treat. Unruptured spectral Martin grade 4 and 5, we do not advise treatment today because of Aruba. 3 we select, and venous angiomas, example, we do not need any treatment for this. Now a little bit about Aruba. As you know, Aruba was a randomized multicenter clinical trial of unruptured brain AVMs, and this was in 2006 by J.P. Moore, who was a neurologist, and that was really a problem. I'll tell you why. This is a beautiful study because it's a prospective, the first prospective controlled multicentric trial. The problem was they put all the types of intervention in one arm and medical management in one arm. Medical management and all types of intervention like microsurgery, radiosurgery, embolization. The eligibility criteria above 18 years. And the only problem was deemed suitable for complete obliteration. This was a subjective thing, and the patient should not have any treatment before that. And there was no clinical trial data comparing various therapy. There was lack of consensus. And so this is how this treatment started. This was devised. And the microsurgery, you know, there was multiple studies which are different outcomes. So this was studied. Now, what are the data? The patient was screened, was 1,740 patients were screened, but only very few patients were randomized, only 13%. That's one of the problems. And the primary outcome was death or symptomatic stroke. I'll come back to that. And secondary outcome was clinical impairment, grade MRS more than 2. Now, as I said, initial plan was 800 cases, but it was devised to 400 cases. Finally, only 226 cases were studied. Medical 119, 9 intervention was 114. Study stopped in 2013. Was follow-up was only 33 months. Now, radiosurgery, you cannot usually give a treatment modality if you are followed up for only 33 months. And more than that, at the time of analysis, 64% of the patients had, 73 patients had not even been treated, and 53 had not completed treatment, 20 not initiated. So the recommendation of this Aruba study was based on 41 patients only who completed treatment. And there was only 5 patients who had microsurgery. The whole Aruba study was based on only 5% were pure microsurgery and multimodality 28. And intervention, most of the patients had endovascular treatment. The primary endpoint was better in intervention. As you can see, we go to a little bit in the depth. There are actually no difference in mortality in both the groups, the medical management and intervention group. However, the stroke, as they describe stroke as any new significant focal neurologic deficit, any seizure was also, and new onset headache with associated MRI changes. And these increases significant the morbidity in the Aruba group for the intervention group. So there was bias towards non-surgical therapy, there was shortage of surgical expertise, and the very short duration of studies. Very low randomization in UCSF, only 4 included out of the 473 screened in there. As I said, only 5 cases had pure microsurgery. So short study duration and very few cases were actually treated. What it just did so, the lower rate of complete AVM obliteration embolization, which you already knew, and their higher rate of delayed hemorrhage in embolization. There was a very short surgical expertise. As you can see, stroke and death rate was 31%, 1 in 3 in this group, which had very few patients were treated, but 1 in 3 had this kind of stroke. Now, if you see in the literature, Morgan from Sydney, Spetzel Martin grade 1 and 2, only 1.6%, Lawton 14% when included grade 3. In our practice, 1 and 2, mortality nil and only 2% stroke. So 31% was very high in this Aruba. Now what happens if you observe Aruba as was advised? Observation when an unruptured AVM. This is such a patient which was treated by our neurologist, observed, hemorrhaged, had to go for a decompression, but it could be taken out and has a complete cure. So this should have been treated to my mind. It's a young patient. It's a young girl, actually neurosurgeon's daughter, who presented with headache because a neurosurgeon's daughter, she got an MRI. This AVM was diagnosed, unruptured, observed, hemorrhaged, and developed homonymous hemianopia. But there is some strength of Aruba. It's the first randomized international multicentric trial. And we did find out that endovascular treatment for cure is not appropriate. And we did notice again that spontaneous rupture rate is 2.2%. Post Aruba in the literature, there has been no change in the proportion of unruptured AVM before and after Aruba. This is Steinberg from Stanford. In our practice, microsurgery post Aruba, Spetzel Martin unruptured AVM, Spetzel Martin 1 and 2 young patient surface, gamma knife in deep location and combination treatment. We observe in 4 and 5 elderly and brainstem, and Spetzel Martin grade 3 patient unruptured, we would multimodality treatment. So bottom line is proper selection. Thank you very much for your attention.
Thank you, Professor Misra, for saving us first for this absolutely impressive talk and for saving us a few minutes for questions. So I know that you have answered some of the questions on the chat, but let's share them with the rest of the audience for them to have the same benefit. So the first question about the occlusion of the carotid in the neck and its effect on the vision.
Yeah, so if you occlude the carotid in the neck, there is no problem with the vision. I haven't seen ever. But if you're going to trap the ICA, the intracranial clip trapping should be proximal to the ophthalmic. Otherwise, that can be a risk to the, even though you can get away most of the time because the central retinal artery gets compromised, you lose the vision. So ophthalmic, if you take it, there are collaterals from ECA and the opposite side. So you may get away, but it is a good practice If you want to trap it, it has to be proximal to the ophthalmic artery in the ICA, and you need to drill the clinoid for that.
Yeah. So another question for actually both professors, and I would like to have a comment from both of you. And it's about, it's kind of a philosophical question, because with the advances that we are seeing every day with the endovascular, so the amount of cases which are getting referred for neurosurgeons for microsurgery are becoming less and less. And the fact that the most difficult cases, the most complex cases are referred for neurosurgeons for microsurgery, well, they're not trained for the easy, straightforward cases. So in the era of the endovascular surgery, how can we expect the neurosurgeons in the future to do the complex cases without having the experience that we all know on doing the straightforward cases? So we start with Professor Misra and then Professor Ghannam.
Well, it's a real problem. It's a real problem for training, because more and more simple cases go for endovascular treatment today, and more difficult cases, failed treatment, come for microsurgery. So you find complex cases, and so to train young neurosurgeon becomes difficult. So to my mind, one of the solution to have centralized teams, teams where all the facilities available. Not everybody should be doing aneurysm. There should be referral center where they should be treated. So you have a number of cases, and that can be done. And the other thing which will stand in the test of time is learning the bypass techniques, because the ones which are complex can be treated more often by bypass. And bypass is a young neurosurgeon can learn in the lab, and they are actually much better off because their tremor is less. So they need to go and learn the bypass techniques in the lab. But it's a real problem. The next generation of neurosurgeons will have a problem in tackling more and more aneurysms.
Professor Ghannam?
Yes.
It's 16
yes,
hours.
I'm sure that we're seeing less and less. But mind you, any skull-based surgeon will do any aneurysm whenever comes easily. Number one, because he's used to the anatomy and the basic anatomy of the skull base, cervical villus, optic nerves, and so on, and cervical villus, all of it. And number two, in aneurysm, you're working in a normal brain, unless you have an angry brain. But in brain tumor, you work with the angry brain, edema, large tumor. So I wouldn't see a difficulty. The other thing is that you wouldn't, if we go classically, no neurosurgeon can go to whatever type of surgery, transsphenoidal, skull base, unless you go to the lab. Lab is very essential. I used, when I was a young lad in England, in Southampton, they put me on the lab with the white track, doing anastomosis between both carotid arteries behind the trachea and esophagus. And I have to do that, then inject radioactive carbon, and then take the brain. I mean, lab and anastomosis is necessary. When I came back, I tried to do that, but I found difficulty. So I suggested to take the placenta from the gynecology department and take the vessels and make some anastomosis to make the handcraft of anastomosis, because it's not the problem of trapping or putting a clip on the aneurysm. The problem how to deal if you are artery is occluded. You have to do anastomosis, STA anastomosis, MCA, or vertebral occipital-vertebral artery anastomosis. I mean, lab is essential, but I wouldn't think it's great difficulty. If you are a skull-based surgeon, it's a piece of cake. I remember Graham Steer and other people in Gillingham in Scotland. They say, I do the aneurysm surgery in 20 minutes. So because you're working on a normal brain. That's it. Thank you.
Thank you, sir. And I believe we can't make you late more than this. So we thank our distinguished speakers, Professor Dr. Basant Misra, the first Vice President of the WFNS, the President of the World Federation of Skull-Based Society, and the Honorary President of the Australasia Neurosurgery Society, and Professor of Head of Neurosurgery Department of Hinduja Hospital, Mumbai. We also extend our thanks to our very own Professor Dr. Usama El-Ghandour, Professor of Neurosurgery at Al-Azhar University, Honorary President of the Egyptian Society of Neurosurgery, former dean and of Al-Azhar University, and of course.
Let me also thank you. Let me thank Professor Basant Misra for contributing to this webinar. Thanks to Professor El-Ghandour. Thanks to Professor Amr El-Samman. It was a great, successful webinar as usual. Let me announce that, Basant, let me just 1 minute, Basant, please. Next Friday, we have skull-based webinar. At the same time, Professor Luis Borba, Professor Khaled El-Bahi, and moderator Professor Amr Safar. Thanks to all of you for contributing to this webinar. Thanks, Basant. Goodbye.
Thank you.
Thank you very much.
نورتنا يا دكتور أسامة.
شكرا جزيلا.
كنت عايز أعدي على حضرتك. أعدي على حضرتك إمتى؟
أنا بشتغل كل يوم من 10 الصبح لغاية الساعة 4. تعالى الساعة 2 أكون خلصت.
ده حتى بعد المواعيد الجديدة؟
والله لسه المواعيد الجديدة، أنا ما قررتش أشتغل بعد الظهر ولا لا.
طب يوم إيه طب يا دكتور أعدي على حضرتك؟
أنت تشرف بيه.
الله يخلي حضرتك.
تعالى يعني يوم الاثنين أو الثلاث إن شاء الله.
طيب خلاص، عايزين نوفر بقى الأنسيلا كوكس عند حضرتك.
يا ريت ان شاء الله.
خلاص
قريب يا دكتور. ميرسي جدا لحضرتك. ان شاء الله نزور حضرتك قريب جدا.
ربنا يخليك.
ميرسي يا دكتور اسامه.
شكرا.
باي باي، مع السلامه.
سلام.